I'm Dr. Sheetal Shroff. I'm a neuromuscular neurologist at Houston Methodist Hospital. Today, I'll be speaking about advances in hereditary amyloid polyneuropathy, also called as hATTR amyloid polyneuropathy. These are my disclosures. Overview of my presentation consists of review of types of amyloidosis, epidemiology, pathophysiology, diagnostic tools, and advances in treatment. One of the earliest mention of this disease was in 1952 by Andrade. This condition was mentioned as foot disease. This is an endemic disease with the following characteristics: paresis in the lower extremities, early impairment in thermal and painful sensibilities in the lower extremities, gastrointestinal disturbances, sexual and sphincter disorders. Amyloidosis is labeled as a rare disease as well as an orphan disease, meaning that all types of amyloidosis combined affect less than 200,000 people in the US population. One reason maybe is lack of early diagnosis, possibly from lack of awareness. Systemic amyloidosis is classified into three major types: transthyretin amyloidosis, also known as ATTR, light chain amyloidosis, also called as AL amyloidosis, amyloid A or AA amyloidosis. Transthyretin amyloidosis is further classified into acquired or wild type and hereditary amyloidosis. The wild type amyloidosis is the non-hereditary form caused by accumulation of amyloid fibrils consisting of wild type transthyretin. It is presumed to be from aging. On the other hand, hereditary form, as the name implies, is the inherited form as an autosomal dominant manner because of one of the several genetic variants in the TTR gene. AL amyloid is caused by accumulation of kappa or lambda light chains associated with conditions such as multiple myeloma. AA amyloid is associated with chronic inflammatory conditions such as rheumatoid arthritis, Crohn's disease, or chronic tuberculosis, etc. For today's presentation, we will focus on hereditary amyloidosis, also known as hATTR amyloidosis. Currently, in the online registry on amyloidosismutations.com, there are about 182 variants of genes known to cause hereditary amyloidosis. Transthyretin or the TTR mutations account for about 68%. Apolipoprotein A1 gene accounts for 13%. Fibrinogen alpha chain gene accounts for 8%. Lysosome gene 5%. Alpha lipoprotein A2 2%. Glycosin gene 2%. Beta-2 macroglobulin gene 1%. And cystatin C gene 1%. Moving on to geographic distribution. The most common variant around the world is the Val50 met, also known as Val30 methionine. It is almost the only variant detected in Portugal, Brazil, and Sweden. By contrast, as many as 30 different TTR variants are reported in Japan and France. Genetic anticipation, that is earlier onset and more severe clinical presentation in successive generation, is noted in endemic areas. In the USA, the most common pathogenic variant is Val142 isoleucine, also known as Val122 isoleucine, predominantly in African American population, followed by threonine 80 alanine, also known as threonine 60 alanine in patients with Irish descent, followed by Val50 methionine. The TTR gene is located on chromosome 18 and comprises of 4 exons. Most of the protein is synthesized in the liver, although a small amount is produced in the choroid plexus, in the brain, and the retinal cells. TTR protein circulates as a soluble tetramer in the peripheral blood and CSF. Under normal condition, it transports retinol or vitamin A and thyroxine. Pathogenic mutation decreases the stability of this TTR tetramer and enhance their dissociation into monomers, as seen here in the picture here and then in the second figure here. And these monomers self-aggregate in the extracellular space, leading to formation of non-fibrillar soluble oligomers and protofibrils that assemble to form insoluble amyloid fibrils. Again, as shown here in the picture, these amyloid fibrils, and these fibrils cause tissue damage. In panel B, here, this is the histopathological representation of amyloid deposition. This first picture here shows increased blood-nerve permeability, which basically results in deposition of these amorphous TTR electron-dense substance in the endoneurium, which eventually leads to formation of amyloid seeds in the form of these dotty structures, which eventually aggregate to form amyloid fibrils and get deposited in the peripheral nerves. These amyloid deposits can also lead to adjacent Schwann cell atrophy. In figure C here, the disease process, including the amyloid deposition, start before the onset of symptoms and signs of amyloidosis. Amyloidosis is a multi-system disease, as the picture depicts. The amyloid can deposit in various organ systems, resulting in multi-system manifestation. The dark pink areas are the sites of amyloid deposition, as we can see in the heart, nerves, kidneys. And the blue areas are the area of sensory denervation, as we can see here. And then the beige area are the area of motor denervation, mainly in the axial region. The organs affected by the autonomic neuropathy or those affected by autonomic denervation are highlighted in green. Now moving on to amyloid deposition in the nerves. Amyloid deposits are seen in the endoneurium as well as in the blood vessels of the endoneurium, perineurium, and epineurium. Over time, it is expected that TTR deposition may spread along the whole length of the nerve, starting from the ganglia and the nerve roots, sensory and motor, where the blood-nerve barrier is more permeable. These amyloid deposits increase the blood-nerve barrier permeability, further foster amyloidogenic material deposition, and promote spreading along the nerve. hATTR amyloidosis can be called as zebra of many stripes. Varying TTR mutations have different predilections for heart or nervous system. As we can see in this picture, certain variations can lead to predominantly polyneuropathy manifestation, and certain variation can lead predominantly to cardiomyopathic manifestation. And there are certain which can cause both. So hATTR amyloidosis is definitely a zebra of many stripes. What are the diagnostic tools available for diagnosing hATTR amyloidosis? Labs include serum protein electrophoresis, urine protein electrophoresis, kappa lambda light chains, serum immunofixation, mainly to rule out AL amyloidosis. NT-proBNP to evaluate for cardiac involvement, electrodiagnostic studies such as EMG nerve conduction study, punch skin biopsy, fat pad biopsy, sural nerve biopsy, genetic testing, and even cardiac PYP scan, which can be used for involvement to detect involvement of cardiac tissue. Autonomic nervous system involvement can be assessed by evaluating cardiovagal function, that is heart rate response to deep breathing and Valsalva ratio, adrenergic function evaluation with tilt table test, pseudomotor function evaluation by quantitative pseudomotor axon reflex test called QSART, thermoregulatory sweat testing, sympathetic skin response. Some of these tests require an autonomic lab with specialized equipments, so one might have to consider that before doing these tests. Some of the common misdiagnoses include CIDP, chronic axonal idiopathic polyneuropathy, carpal tunnel syndrome, or even lumbar spinal stenosis. On the right the figure on the right, it lists all the red flag list, which includes history, certain points in history such as family history or history of bilateral carpal tunnel syndrome, dysautonomia, as well as certain symptoms as well as signs which one has to look for if amyloidosis is in the differential. Moving on to overview of therapeutic strategies. Many treatments have been developed in the last 3 decades, but more so in the last decade. Since liver is the major producer of mutant TTR, the first of these treatments was liver transplantation to suppress the main source of the mutant TTR. The problem with this is continued progression of ocular and CNS amyloidosis and neuropathy after liver transplantation. TTR stabilizers have been developed to stabilize TTR tetramers and thereby prevent the formation of amyloid fibrils. Most recently, TTR gene silencers have been developed to block the mRNA synthesis and thereby reduce production of mutant and wild-type TTR. Wild-type TTR is also targeted owing to its involvement in progression of disease after liver transplantation in late-onset hATTR with polyneuropathy. Timeline of therapies for hATTR amyloidosis, as one can see, there was no treatment available from 1950 to 1990, and after 1990, it was really liver transplantation until 2018. Yes, diflunisal, TUDCA with doxycycline has been used as TTR stabilizers, but really FDA-approved treatments were only in 2018 when inotersen and patisiran were approved, followed by tafamidis, and then vutrisiran and eplontersen. Right now, acoramidis and anti-TTR monoclonal antibodies are under investigation. The rationale for liver transplantation is to remove the major source of genetically variant TTR in the plasma and replacing it with the wild protein of the donor. The best outcome was seen in patients with Val50met early onset disease. In a study where 20-year retrospective analysis of 1,940 patients with hereditary amyloidosis, 20-year survival after liver transplantation was 55.3%. And there were some risk factors which were associated with death. Moving on to TTR stabilizers. Tafamidis is a small molecule that occupies the thyroxine binding site on the TTR protein, which stabilizes the tetramer. In this study, 128 patients were enrolled with Val30met TTR variant who had even early onset disease, mean age of 39 years, and they were given 20 milligrams of tafamidis orally every day. And they were followed over a period of 18 months, and the primary endpoints were NIS, lower limb score, Norfolk quality of life score, as well as the total quality of life score. The assessment of all-cause mortality, which is shown here in this graph, followed by the frequency of cardiovascular-related hospitalization, was superior in the tafamidis group compared with the placebo group over 30 months. We can see here in the second figure that the 6-minute walk test as well as the KCCQ questionnaire was better in the tafamidis group compared with the placebo group. Moving on to the gene silencing therapies, patisiran is a double-stranded small interfering RNA directed against the mRNA of the TTR protein. Apollo study enrolled 225 patients who were randomized into a treatment group who received 0.3 milligram per kilogram IV every 3 weeks for 18 months, and this maintained 81% reduction of the serum TTR levels. And here the primary endpoint was the MNIS +7 score, and as we can see here, the serum TTR levels were way below, and then the MNIS score levels along with the Norfolk quality of life questionnaire were better in the treatment group with patisiran compared with the placebo group. Vutrisiran is a double-stranded small interfering RNA with GalNAc conjugate directed against the mRNA of TTR protein as well. Helios A study enrolled 164 patients who were randomized into vutrisiran group, patisiran, and external placebo. And these patients got 25 milligram of subcutaneous injection of vutrisiran over every 3 months over a period of 18 months. And this maintained 88% reduction of the serum TTR levels. The primary endpoint is the change in the MNIS +7 score. And as we can see here on the figure, the vutrisiran group had way better scoring in both MNIS +7 and the Norfolk questionnaire compared to the placebo group. And the TTR reduction was comparable to that of the patisiran group. Inotersen is an antisense oligonucleotide which inhibits the production of TTR protein. 172 patients were randomized, and these patients received 300 milligram subcutaneously every week over a period of 15 months, and this resulted in 74% reduction of serum TTR levels. Significant benefit in favor of inotersen was seen in MNIS +7 at week 66. However, it did not improve the echocardiographic variables when compared with the placebo. Also had some significant adverse effects such as thrombocytopenia and glomerulonephritis. Eplontersen is an antisense oligonucleotide along with a GalNAc conjugate which inhibits the production of TTR protein. Neurotransform study enrolled 168 patients randomized, 144 to eplontersen group, 24 to inotersen group, with the crossover to eplontersen arm at crossover. And these patients received 45 milligram subcutaneous injection over 4 weeks. And the study lasted for about 66 weeks. And this maintained 86% reduction of the serum TTR levels. The primary endpoints was MNIS +7 score and the Norfolk Quality of Life Diabetic Neuropathy questionnaire at week 66, and it was statistically significant in eplontersen group compared to the placebo. Some of the ongoing research is acoramidis, which is another TTR stabilizer, anti-TTR monoclonal antibodies, which is really depleting the deposited amyloid fibrils. And most interestingly, CRISPR-Cas9 NTLA 2001, and this has been recently FDA cleared NTLA 2001 IND application for the treatment of transthyretin amyloidosis with cardiomyopathy, and this is the first phase 3 clinical trial of an in vivo CRISPR-based gene editing therapy to evaluate NTLA 2001 in patients with hATTR amyloidosis with cardiomyopathy. Last but not the least, we have a multidisciplinary amyloid working group at Houston Methodist Hospital with multiple specialists involving cardiologists, hematologists, orthopedic surgeons, neurologists, nephrologists, hepatologists, bone marrow transplant specialists, whose main motive or aim is to make a positive, meaningful impact on patients with amyloidosis. And we meet once every 2 months, and we also have annual patient conference coming up in March. So please be on the watch out for that. And these are my references. I'm Dr. Sheetal Shroff, and that's the conclusion of my presentation. Thank you for watching it.